Hello, everyone. Welcome to the Evoke Neuroscience Lunch and Learn webinar on recognizing PTSD. My name is Morgan Edmondson. I'm the Medical Affairs Manager here at Evoke, and I'm going to be walking you through today's presentation. Before we go ahead and get started, I just want to ensure that everybody can see my screen and can hear me loud and clear. So if you can navigate to your GoToWebinar menu and in the questions section, if you can just type in, "Yep, I can hear you," then we can go ahead and get started. Okay, great. It looks like we should be ready to go. So today is all about recognizing PTSD, and we're going to be going through a couple different biomarkers to help us do that. So our learning objectives for today are to strengthen our functional understanding, or our understanding of functional physiology metrics, and learn how to recognize key biomarkers of PTSD. So at the end of this presentation, you should be able to describe changes in cardiac metrics associated with PTSD, describe changes in peak alpha frequency associated with PTSD, interpret database comparison EEG head maps and recognize changes related to PTSD, and finally use electrophysiology data to help diagnose PTSD and develop treatment strategies. So starting off with diagnosing and treating PTSD, just a quick overview. I'm sure we're all aware that PTSD is characterized by 4 different things: re-experiencing, avoidance, negative changes to mood and cognition, and hyperarousal. Now, it's estimated that about 8% of the American population will experience PTSD at one point during their life. And I'd like to keep in mind that the vast majority of PTSD cases aren't related to combat, but to other forms of traumatic exposure. So as I go through this presentation, I'm going to have a few case studies that are war veterans and active military personnel, because Evoke does a lot of work with the military. But do keep in mind, if you're a primary care physician, you might be seeing various patients that do have signs and symptoms of PTSD, because traumatic exposure can happen, obviously, in real life, not just in military settings. So symptoms of PTSD often involve anxiety and depression, insomnia, and memory loss. And comorbidity in PTSD occurs very often. So PTSD is often comorbid with disorders like depression, anxiety, substance abuse. And really, comorbidity in PTSD is the rule rather than the exception. So chances are you're going to have a PTSD case that has other disorders and comorbidities going on. Now, medications can provide some symptom relief in PTSD cases, but more often they're not. They're devoid of healing properties. So today I'm going to be talking a little bit about treatment approaches that really target the central nervous system and autonomic nervous system function itself to kind of heal PTSD at the root cause, rather than a medications approach, which sometimes is just kind of masking symptoms rather than curing the disorder. Now, the current gold standard for diagnosing PTSD is CAP, which is a 30-item structured interview that can be used to make a current diagnosis of PTSD or a lifetime diagnosis, and it can be used to assess PTSD symptoms over the past week. So although it's the current gold standard, this approach doesn't use any objective physiology to make a diagnosis. So the typical approach for a PTSD patient, this is kind of the start of a case study, would be to do an interview or perform a neuropsychological screener. And responses to these kind of screeners can vary widely, because PTSD has a lot of different varying symptoms, and symptoms kind of display according to what central nervous system areas are dysfunctional. So you can have memory loss, you can have attention problems, you can have changes in mood and affect, all of the above, a combination of them. So it doesn't present as homogeneously as some other disorders we've talked about. Now, in terms of what is causing symptoms, that's obviously your first question, and it could be a variety of things. You're narrowing it down to PTSD, anxiety, depression, cognitive decline, insomnia, and if the patient is a military personnel, it could be they're experiencing symptoms related to TBI or blast injury. So it's really important to figure out exactly what's causing symptoms and create an accurate diagnosis. And then once you have that PTSD diagnosis, you want to know how to guide treatment. And specifically, we want to be treating the central nervous system and the autonomic nervous system because that's really the root cause of PTSD. Now, of course, the best way to guide treatment of the central and autonomic nervous system is to evaluate those systems directly. So that means we need to be using objective physiology biomarkers to create our diagnosis. So that brings us to objective electrophysiology. So functional neuroimaging via EEG is well-established, non-invasive, affordable, office-based method of brain imaging. You know that because you're using EVOX. And these objective measurements don't rely on patient self-reports. And there's a lot of research-backed EEG metrics out there that correlate to PTSD. I did a quick Google Scholar search of PTSD and EEG. Over 23,000 results popped up. So there's a lot of peer review published literature out there that you can read up on if you're interested in this subject in more depth. And I'll note as well that biofeedback may be used to target and correct nervous system dysfunction related to PTSD symptoms. Now I'm going to draw your attention really quick to the diagram over here on the right. And I want to note that there are a lot of other biomarkers of PTSD outside of objective electrophysiology, which is what we're talking about today. So there are things like neuroendocrine biomarkers, immune biomarkers, psychophysiological biomarkers, and there's really a lot to consider when evaluating PTSD. And today we're really just talking about the brain and the heart. So if you're interested in diving deeper on this subject, this Michael Poulos review article does a really great job of summarizing some of the objective physiology biomarkers you can use. But of course, today we're going to be talking about electrophysiology as it relates to the heart and the brain. So key biomarkers correlated with PTSD. First is ECG heart rate variability. We're going to be looking for sympathetic dominance. Next, we're going to look at EEG resting state, specifically an elevated peak alpha frequency. And then we're going to look at EEG head maps. We're going to be keeping an eye out for high power in the alpha and beta bands in the eyes closed conditions. And I also want us to keep an eye out for different Brodmann areas of interest because there are a couple brain networks that are known to be involved in PTSD. So when you get a Brodmann area that's responsible for brain dysfunction, that's kind of the cherry on top with a clear-cut PTSD case. Now, as usual, we're going to walk through these metrics and what they are, and then how they relate to PTSD. I'm going to go through metric definitions a bit more quickly this time, because if you've been joining me for past webinars, they should be pretty familiar to you. But if this is the first webinar you've attended and you'd like a more in-depth review on what the metrics are, so shoot me an email and I can send you a recording that's designed specifically for a review of the metrics. All right, so starting off with heart rate variability, we know that heart rate variability is synchronized electrical activity between the brain and the heart. And it's really this heart-brain interaction that can give us insight to the autonomic nervous system. So looking at heart rate and blood pressure, cardiac output can tell us if the system, if the autonomic nervous system is shifted towards sympathetic dominance, our fight or flight mode, or if it's shifted towards parasympathetic dominance, our rest and digest, or ideally, if it's balanced between the two. Now, the specific metric we're going to be looking at in the heart is called heart rate variability. That's the measure of neurocardiac function reflecting the heart-brain interaction and the autonomic nervous system dynamic. There's two ways we can think about HRV. The time domain, which is how variable is the heart beating on a beat-to-beat basis, And then the frequency domain, which is how balanced is the autonomic nervous system between that sympathetic and parasympathetic activity. Starting off first with our time domain, the question is, how variable is the heart beat to beat intervals? Now, contrary to what your patients might think, the heart is not a metronome, it's actually erratic. And a healthy nervous system responds in real time to what the body needs. So an ideal heartbeat variability is high. If it can hold out a split second longer before giving that next pump of blood, it's going to do that. So you're going to get high variability between beats on a beat-to-beat basis. Now, one domain metric of HRV in the time domain is called SDNN, the standard deviation of end-to-end intervals in milliseconds. And as I noted, we're looking for a high SDNN. And high SDNN is shown to be correlated with good overall heart health, good autonomic resilience, and low stress levels. Now, when we think about HRV in the frequency domain, we're asking what are the underlying rhythms in heartbeat to beat intervals. So just like the brain, the heart beats in rhythms that can be graphed according to frequency. And this is an example on the top bar of the original waveform of heart rate variability. We use a computer algorithm to filter this waveform into very low frequency waves, VLF, low frequency waves, and high frequency waves. Now, it's important to do this filtering process because this VLF, LF, and HF frequencies correlate to different physiological processes and really show us sympathetic, balanced, and parasympathetic activity within the autonomic nervous system. So then the question becomes, how much power does each underlying rhythm have? And power is basically just asking how much of each rhythm is present. So here on this graph, on the x-axis, we have our frequency ranges, very low, low, and high frequency. And on the y-axis, we have power, how much is there. And remember that our very low, low, and high frequency relate to sympathetic, balance, and parasympathetic activity within the autonomic nervous system. So again, power is reflecting strength of vagal activity. And ideally, we would like to see the highest power in the low frequency band, because that would mean the autonomic nervous system is balanced between sympathetic and parasympathetic activity. So how does HRV correlate to PTSD? What are the biomarkers we should be looking at? There's a great meta-analysis study from 2013 that kind of summarizes all of the research articles out there that are looking at HRV and PTSD. And a couple things I want to note from their overall conclusions that really stand out. The first is that PTSD patients have a reduced high frequency HRV. So that means they're going to be shifting away from the high frequency parasympathetic activity and shifting toward sympathetic activity. So they're going to be more the stressed out fight or flight type of autonomic nervous system activity. And simultaneously, there's an increase in the low frequency to high frequency ratio. That's basically the same way of saying they're shifting toward that fight or flight response. So on a bar graph point of view, what you're going to see is a decrease in this high frequency parasympathetic activity and an increase in this very low frequency sympathetic activity. Now, I'll also note that overall PTSD patients have elevated heart rate and they show reduced SDNN. Now remember, SDNN is our time domain metric of heart rate variability, and ideally we're looking for high SDNN, and here PTSD patients show low SDNN. So overall, we can be on the lookout for a reduced HRV and an increase in sympathetic tone. So how does that look on the EVOX report? Remember, you're keeping an eye out for sympathetic dominance. And that is shown here in this bar graph. You will look out for an elevated sympathetic power. Now, you might see concurrently an elevated parasympathetic power, and that basically means somebody is stressed out in fight or flight mode, and they're really tired and exhausted of being in that state. And remember that ideally we're looking for the reverse of this view, and we would see a highest peak in the balanced bar, but that is not the case typically for PTSD patients. Now, also keep an eye out for reduced SDNN, meaning a lower number than normal, and an elevated heart rate. Okay, so that sums up our cardiac metrics of interest. Let's move on to talking about peak alpha frequency. So that's the frequency within the alpha band where the highest amplitude occurs. So we're talking about EEG here, and remember that EEG frequency ranges from delta to beta, and delta are slow waves, beta are fast waves, and we're interested here in alpha, which is kind of the typical resting state frequency of the brain. And within alpha, we're looking for the peak amplitude, and that is hence called peak alpha frequency. Now, peak alpha frequency is an overall measure of cognitive ability, and it's generated by the thalamus and reflects thalamocortical network activity. What does that mean? Basically, think of it as the pacemaker of the brain. So it's kind of setting the overall tone for brain health, cognitive capacity, etc. Now, remember, in the past, we've talked about inter-individual differences in peak alpha frequency. So things like age, education level, memory performance, and innate intelligence all affect peak alpha. So, for example, age, peak alpha frequency starts out slower in children, so it'd be shifted over here. It gets faster in adulthood, and then it shifts back down to be slower again in the elderly. And education and intelligence is generally correlated with a faster peak alpha frequency. And an ideal peak alpha frequency, because of all these inter-individual differences, is a range. 9 to 10.5 hertz is usually a good range, and somebody at 9 hertz could be just as healthy as somebody at 10 hertz. It just means they might have a bit of a difference in overall cognitive capacity, you know, their education level. Do they have a doctorate degree, or did they barely finish high school? Things like that. Okay, so peak alpha and how it relates to PTSD. In general, if you've attended Lunch and Learn webinars in the past, you should remember that generally the lower the peak alpha frequency can be indicative of cognitive decline, and the higher or the faster the peak alpha frequency can mean stress and anxiety. So it's no surprise then when we look at PTSD patients compared to a control population that PTSD patients have a faster peak alpha. So in this graph, on the y-axis, we're looking at peak alpha in hertz, and on the x-axis, we're looking at different locations you can measure peak alpha in the brain. So globally, peak alpha in the PTSD population in this light gray bar was faster than controls. And the same was true when you measured peak alpha in anterior locations, so toward the front of the brain, posterior toward the back of the brain, on the right and on the left. So overall, no matter where you're measuring peak alpha, it's faster in subjects with PTSD. So this is a fairly easy thing to keep an eye out for on EVOX reports. It's one simple number, which is great. Sometimes it's more complicated than that, as we're going to talk about in our next biomarker EEG head map. But for peak alpha, you're just looking for faster than 11 hertz. And I'll note, though, that it's not a single diagnostic biomarker that can be used on its own in isolation. So when you see a peak alpha of 11.4 hertz, that doesn't mean automatically PTSD, right? It could be a general biomarker of anxiety disorders, so it's not specific to PTSD. And I'll also note that children have a slower peak alpha, and they really reach an adult peak alpha level once they're around 10 years old. So a fast peak alpha for a child with PTSD could be around 9 hertz. Just keep an eye out for that when you are treating children that have been exposed to trauma. You're going to see something like 9 and think that's normal, because that would be normal for an adult, but for a child that's very fast and could be a biomarker. All right, so our third biomarker we're talking about is quantitative EEG. We know that EEG measures electrical activity on the surface of the brain. And we're really interested in two factors: frequency, the speed of brainwaves, and power, which is the amount of activity within each frequency. Now, to quickly orient you before we get to our head map, this is a head, kind of an aerial view down. The nose is at the front, back of the head is at the back, and we have left on the left and right on the right. And all of these circles denote placement of different electrodes. Now, today we're also going to be talking, in addition to our surface EEG activities, we're going to be talking about Loretta imaging, which can source localized dysfunction even within deep brain structures. So when we look at our head map here, this is just surface activity. And if I see dysfunction in the frontal part of the brain, that doesn't necessarily mean the frontal lobes are the problem. It could be a deep brain structure that has dysfunction that is kind of manifesting as dysfunction on the cortical surface. So Loretta is a way that we can source localize where the dysfunction is happening, even within deep brain structures. And Loretta imaging is what we're using when we talk about specific Brodmann areas, which we'll get to in a bit. Okay, so EEG frequency, remember frequency is talking about the different brainwave rhythms that's created by neural communication. And frequency is measured in cycles per second, so hertz, of the brain's electrical activity. Now, we have ranging between slow waves all the way to fast waves. And these frequency bands are called delta, theta, alpha, and beta. And it's important to keep in mind that these frequency bands correlate to different kinds of behaviors. So in general, slow frequencies correlate to slow behaviors. So somebody in deep sleep will be producing a lot more delta than they would if they were awake. And fast frequencies correlate with fast behaviors. So right now, I'm producing more beta than I would if I were just calmly sitting here relaxing. So power is reflecting the amount of electrical voltage present within each frequency. Now, I'll note that all frequencies are generated in the brain at all times, but it's the amount of each frequency being produced that changes depending on what the person's doing or a clinical disease state. So as I said, right now, I'm creating more beta than I would if I were just sitting here resting. And somebody with a specific disorder or disease might be producing different amounts of different frequencies. And that's where this quantitative EEG comparison to a normative database is coming in. And to compare your patients to a normative database, we're going to be using Z-scores, which is how many standard deviations away they are from normal. So how far off are they? Are they producing way too much of a certain frequency, which is what we're going to call high power, or are they producing way too little of a certain frequency? And remember that power here is basically reflecting neural recruitment. All right, so interpreting our head map. The first question is, what frequency are you looking at? Is it slow or is it fast? Remember that our slow frequencies are generally 2 to 10 hertz. It includes delta, theta, and the first half of alpha. And then 10 to 30 hertz is our fast frequencies. So the second half of alpha and then all of beta. And just I'll note, there's a little frequency key down here on your EVOX report. So you don't necessarily have to memorize where these things are cut off, but just in general know these first two lines are our slow waves and then the rest is our fast waves. Then you want to be considering what power. Is it low or high power? So is it blue or is it red? And remember that we're comparing your patient's brain to a normative database. So ideally, we would like to see green in all frequencies, which means that your patient is not differing from the control database. They're right on point. And finally, we're interested in what brain region the dysfunction is in. Now, this is important because it can give insight to PTSD symptoms. So things like insomnia, mood regulation, attention, and memory problems can be revealed through a chart like this. Now, for an example, I can tell that this person might have PTSD because this is the biomarker we're going to be looking for, this high power in the back of the head in kind of the alpha beta range, and we'll talk about that in a moment. But I also see that they have low power here in the theta band. That could be meaning that they have trouble sleeping. They might have insomnia, they can't really fall asleep. And it also looks like they have low power here in alpha, and that could mean they have a comorbidity diagnosis of depression. They could be depressed and have PTSD, they can't sleep at all, they can't regulate their mood, classic PTSD symptoms. All right, so EEG and PTSD. Let's look at a study that compares veterans with combat-related PTSD to healthy subjects. Now let's first look at the y-axis. We're looking at power within the beta frequency band, so 13 to 18 hertz. And here on the x-axis, we're looking at different regions in the brain. So F3, F4 correlate to these electrodes. C3, C4 are in the central region, and then O1 is back here in the back of the head. And you'll note that PTSD in the teal bar compared to controls have higher power in all of these locations. So when you put it on a head map, you're looking for high power in this kind of central back of the head region. And that's what we're going to be looking at in the beta band. So we're looking at fast frequencies, kind of that alpha beta intersection around 11, 12, 13, 14 hertz. And we're looking for red, high power, in kind of the central posterior region. So I will also note that we can use Loretta imaging to kind of source localize this surface dysfunction and see what's going on kind of in deep brain structures. And that's really important to do because there are a lot of different brain networks that are known to be impaired in PTSD. So first, we can talk about the central executive network. That's responsible for verbal learning and executive functioning. And so if somebody has this network affected, they're going to have symptoms like executive and cognitive dysfunction. The salience network is responsible for directing behavior for kind of the most appropriate response. So symptoms related to this network when it's disrupted is kind of hyper or hypoarousal, sensitivity to internal stimuli, and then the default mode network, which is kind of autobiographical memory, social cognition, self-referential processing. And that's really where the hindered or altered sense of self comes in with PTSD. So because these networks are known to be related to PTSD and kind of disrupted in PTSD, we can look out for specific Brodmann areas of interest that have dysfunction in our EVOX report. So somebody that has dysfunction in these Brodmann areas and also has all the other biomarkers we're looking at related to PTSD is a kind of a clear-cut PTSD case. Now, I'll note that EVOX reports only the top 3 most deviant Brodmann area regions. So that means that there could be more regions that are significantly deviant from our control population, but we're just talking about the top 3 that are the most far away from our control database. Now, keep that in mind, because if there are artifacts present within your EEG data, so like muscle movement or eye movement, those are typically very deviant. Remember, we've talked about recognizing muscle and eye movement. It's always very, very, very high power. So of course, that's going to be many standard deviations away from the norm because it's an artifact. So the regions truly responsible for brain dysfunction wouldn't be displayed if an artifact is present. Usually, that's typically the case. So kind of always take your Loretta results with a grain of salt. If you have muscle and eye movement artifacts present, chances are the Loretta results are going to be reflecting that, rather than reflecting the true Brodmann areas you're interested in that's causing, the surface dysfunction. Okay, so QEEG and the report, what you're looking for. First, high power, fast frequencies in posterior regions. So here I'm looking for high power, and this is my alpha beta intersection, this 11, 12, 13, 14 hertz brainwaves. And it's in the posterior region, and it's only in the eyes closed condition. So that's really interesting with PTSD and kind of really makes it clear to pop out at you. So when you have the eyes open condition, I don't see any of this high power in my alpha beta frequencies. But when the eyes are closed, all of a sudden, I'm producing a lot more of this frequency in my posterior brain regions. So you can kind of think of that as like, once the eyes are closed, the brain can't see what's coming, and it kind of kicks into hyperdrive, and that anxiety, stress, all of those things kick in because the brain has no idea what's going on in the outside world. So we're looking for kind of this red in the back of the head and 11, 12, 13, 14, and especially when it's present only in the eyes closed, that's a very clear PTSD biomarker. And of course, don't forget our Brodmann areas of interest. So using our Loretta results, if we see that any of these different areas, the insula, the anterior cingulate, posterior cingulate, medial prefrontal cortex, fusiform gyrus, perennial cortex, and the precuneus, if those are affected, it's kind of the cherry on top, definitely PTSD. One of those brain networks we talked about being related to PTSD is affected, and that is why that patient is having those kind of symptoms. All right, so a quick summary that we've talked about today. Biomarkers correlated with PTSD. First off, we're looking at heart rate variability, and you want to keep an eye out for sympathetic dominance. Then we talked about peak alpha frequency. You're looking for peak alpha faster than 11 hertz. And resting state, EEG, we're looking at head maps with high power in posterior regions in the alpha beta bands, and especially when that's present in eyes closed but not eyes open. And we're looking out for our Brodmann areas of interest. All right. And of course, there's more. This review article that I talked about at the beginning of the presentation does a great job of summarizing not only these kind of biomarkers, but also neuroendocrine biomarkers like steroid hormones and metabolic hormones, immune biomarkers, things like interleukin-6 and C-reactive protein, and then other psychophysiological biomarkers. It's not just HRV that's affected, things like skin conductance, respiration rates, and startle response. So if you're interested in more, there's always more. All right, so diving really quickly into case studies before we wrap up. This is a 38-year-old male with headaches, anger, anxiety, and insomnia. And let's kind of go through and see if we recognize any of the biomarkers. So first, starting with heart metrics, the first thing that jumps out is this is somebody that does have a balanced autonomic nervous system, which is great. Doesn't have the sympathetic overactivation, but I do see a reduced SDNN. So his heart rate variability is definitely reduced, and that's a biomarker of PTSD. Let's look over here at our peak alpha frequency at 12.4. That's a very high peak alpha. And when I look at our head maps, I see high power at the back of the head in this 12-13 range, and it's only present in my eyes closed. So that's a biomarker we talked about. And when we look at the Loretta results, the anterior cingulate for this patient was causing a lot of this surface dysfunction, and that's one of our areas of interest. So overall, I'm going to conclude that this patient likely has PTSD, and they also likely have depression. Now, I'm getting depression because I see low power in frontal alpha, and that is a clear-cut depression biomarker. Now, if you're not familiar with why that makes sense, we have a depression lunch and learn webinar that I can send you. Just shoot me an email and ask for it. All right, so next up, we have a 63-year-old female. She has fatigue, depression, trouble concentrating, a lot of memory problems. And looking at our heart metrics, she has sympathetic activity, also a lot of parasympathetic activity. So that's why this fatigue is coming into play. She's stressed out and tired of being stressed out. She also has a very reduced SDNN. So I'm pretty concerned with her heart metrics. And when I look over here at her peak alpha, she's got a very high peak alpha at 11.5. And when I look at her head map, she's got clear cut, high power, back of the brain, 12-13 hertz, and it's only present in eyes closed. Now, this patient didn't have any Brodmann areas come up. Now, that doesn't mean that this isn't a PTSD case. It's a very clear-cut PTSD case. But, you know, that just goes to show sometimes the Brodmann area, if you see it, it's kind of the cherry on top. But if you don't see it, it doesn't mean it's not PTSD. So, in fact, this patient has chronic PTSD since childhood, and she also has depression going on. Again, looking at that low power, it's shifted toward the left, that left asymmetry in alpha, that's also clear-cut depression. Okay, so a 38-year-old male returning from combat. Let's look at his heart rate variability, and he's actually in pretty good shape. He's got a balanced autonomic nervous system and a very high total power, an SDNN that's within range. And this is not abnormal, even in some PTSD cases, if you're talking to patients that are in extremely good shape. I mean, this is, I think he's a Marine, and so he's very in shape, and so it doesn't mean that he's not going to have PTSD. Definitely look out for the other biomarkers, but kind of keep that in mind. And when we get over to his peak alpha, though, 12.5, that's exceptionally high. And then when we look at his head map, he's got high power in posterior regions, in this a little bit in 12, 13, 14, and it's only present in eyes closed. And when we looked for his Loretta imaging, his posterior cingulate was lit up. So this is likely a PTSD case, despite this heart metrics, being in pretty good shape. I would imagine that once he receives proper treatment for his PTSD, this SDNN number will shoot way up. So it can even improve from there. And again, this looks like he has a depression comorbidity diagnosis, this low power in frontal regions in that alpha range. And then let's look at this woman. She's 54. She's got a history of hypothyroidism, and she came in because she has trouble sleeping. So her heart rate variability is not in great shape. She's got a pretty low SDNN, and her activity is shifted towards sympathetic dominance. Her peak alpha is 11.1. So that's past our 11 hertz general rule of thumb cutoff. It's not as high as we've seen in some of our other cases, but it's definitely high and worth taking note of. And then when we look at our head map, I am seeing some high power in the back of the brain in this 11, 12 frequency range. And it's only present in eyes closed, not in eyes open. Sure enough, when I look at the Loretta imaging, her posterior cingulate is lit up. So interviewing this patient actually kind of revealed that she had a history of childhood attachment trauma. Now, she didn't have any PTSD symptoms and definitely does not need a PTSD diagnosis because she doesn't have any of the necessities to make that kind of a diagnosis. But this is kind of what we could consider a functional scar. Her peak alpha is high, and she has a little bit of high power back in the back of the head. And it just means that her brain has kind of changed the way that it's functioning. She is functioning normally. She truly doesn't have PTSD, but it's just that uncovered history of childhood attachment trauma. Now, sometimes you can see a case like this, and when you see these kind of subtle biomarkers of PTSD, a little bit high alpha, this sympathetic activity and all these little things, it's not a clear-cut case, but it should certainly make you think, I wonder if this person has something else going on. And usually, if you ask them a couple questions, kind of begin that CAPS interview, that's when the tears start coming. That's when you uncover this whole, traumatic experience, and then you can move forward with developing a treatment plan from there. So do keep an eye out. It's not just the super obvious cases. Sometimes you do see these subtle things, but they are there, and you can, kind of uncover some surprise trauma that you didn't know was there. All right, so now let's look at an 18-year-old male. Unfortunately, we don't have heart rate variability metrics because this data collection, they didn't put on any of the EKG leads. So always have your technicians do that. It's important to get all the data possible just to kind of round out your diagnosis as much as possible. But I'm looking at peak alpha. I do see an elevated peak alpha. But now when I'm looking at the EEG head map, I'm seeing high power in the front of the brain. It's shifted to higher frequencies. Now, instead of looking at this 11 to 14, I see it in 19 all the way through 25. And it's present in eyes open and eyes closed. So this does not match what we're looking for PTSD. And sure enough, none of our PTSD regions of interest pop up for Loretta imaging. So this makes me think it's definitely not PTSD. And if I go back and look at all of the other metrics available to me, for this case, I noted that there's a slowed response speed. It's delayed P300A and B. It has a normal theta beta ratio as seen here, but it's got all of this excess frontal beta happening, too much power in this frontal region in the beta band. And this is probably ADHD. It's the beta subtype of ADHD. We talked about this last month. So if you're not familiar, if you didn't look at this and immediately think, hey, it might be ADHD, and go and look back at that presentation. This is the subtype of ADHD that probably isn't going to respond very well to stimulants. So keep that in mind. And finally, finishing up with a 51-year-old male. Our heart metrics looks like we have too much sympathetic activity, also that parasympathetic, tired of being tired, and reduced SDNN. We have a pretty normal peak alpha. This is not elevated peak alpha, 9.6. That's great, in good shape. And when we're looking though at the EEG head maps, I'm seeing high activity or high power, but it's the front of the brain. And again, it's kind of this 19 to 24. But this does look different than our previous case because it's kind of more concentrated in one specific area. So it's definitely not PTSD, but when I look at our other biomarkers, I'm seeing a slowed P300B. And like I said, we have that excess frontal beta with a focal point. So this turns out to be a TBI case. When we interviewed the patient more, it turns out he had a car crash a year ago, and he's suffering a lot of symptoms related to that because his brain hasn't recovered from that TBI. So if you're not familiar with TBI biomarkers, again, we have a webinar for that too. All right, so wrapping up with treating PTSD, the usual approach is with medications, and you know, these are great because they can provide certain symptom benefits, but they're typically devoid of healing properties. So I'm going to be talking about biofeedback, which is a very effective intervention for PTSD. And it's really just a process of training an active balancing between the sympathetic and parasympathetic branches of the heart rhythm. And specifically, HRV biofeedback can be shown to increase HRV and balance autonomic nervous system. So this is an example of before training, we have all of this sympathetic activity, and then after training, we're perfectly balanced between sympathetic and parasympathetic. And that's great. Remember that heart rate variability is one of those key biomarkers in PTSD. So correcting that problem oftentimes corrects a lot of the symptoms of PTSD. Now, I'm also going to mention eye movement desensitization and reprocessing, or EMDR. And this is not a verbal therapy, so it ignores the linguistic narrative of PTSD, but it's been placed in the A category, so it's strongly recommended for the treatment of trauma. And actually, an acute single episode trauma can often be resolved in 6 to 8 sessions using this EMDR approach. And it's kind of doing the same thing as HRV biofeedback. It's increasing HRV and decreasing the resting heart rate, which is usually elevated in PTSD cases. And really an ideal treatment might be a combination of this HRV biofeedback and EMDR. So that wraps everything up. All that is left is our knowledge check. So follow along, try to answer these with me. So heart rate variability, what kind of frequency is shown to be reduced in PTSD patients? Remember, we are looking to see sympathetic activation, but that is a consequence of a reduction of high frequency reduction. And I just gave it away. This results in sympathetic dominance. And for peak alpha, what are we looking for in PTSD patients? We're looking for faster than 11 hertz, unless it's a child, of course, keep that in mind. For QEEG biomarkers, we're looking for red, so high power. We're looking for the back of the head, posterior region. We're looking on that kind of alpha beta intersection, so that's fast frequencies. And we're looking for in the eyes closed condition. And it's a dead giveaway if it's present in eyes closed, but not eyes open. And finally, Loretta imaging can be used for source localization. So it can source localize all of that dysfunction, even within deep brain structures, rather than just cortical activity. So that wraps up our PTSD presentation. I certainly hope you enjoyed it. If you have any questions, feel free to shoot them my way. and I appreciate you attending. Have a great day.